Yeah, for the minute, yeah.
Right, we'll get started. So welcome everyone. Thanks so much for coming along to this ARC seminar today on rapid evidence synthesis. So my name is Pete Bower. I lead with Joe Dunville the evaluation theme within ARC, and throughout our time on that theme, rapid methods have been a real focus for us. We thought some of this would the work that we'd be doing would be around rapid evaluation using routine data, but actually the things that's had the greatest impact and the greatest success has been rapid evidence synthesis. And so today we're going to hear from a couple of speakers, Gill Norman and Theodora, talking about the processes involved in rapid evidence synthesis with some examples of the work that they've been doing. The idea is we're going to do two presentations back to back. If you've got questions, leave those till the end and we'll take them as a whole, or feel free to put them in the chat as we go along. We are going to record this session, so if you're unhappy with that, if you would like to vacate the premises now, otherwise we'll stick the recording on. And if everyone's happy, we'll dive straight in. So it's with great pleasure, I'd like to ask Gill Norman, who's absolutely led this work for us within our absolute expert in this area. So Gill, you're going to start us off with the issues around rapid evidence synthesis. Over to you.
Cleverly managed to mute myself there instead of actually trying to share my screen. Right, I should be sharing my screen now if people can see my slides. Brilliant, thanks everyone for coming. I really appreciate it in the week when everyone's busy trying to get things finished before Christmas. So I was going to talk a little bit about rapid evidence synthesis, the approach we're using in ArcGM, and a sort of expanded example that we did looking at virtual wards. So what is rapid evidence synthesis? Well, it sits in a sort of hierarchy, I suppose, or set of possible approaches which balance rigor against speed in terms of the product that they can deliver and the time in which they can deliver it. And as I'm sure many of you know, at the top of that would be sitting the systematic review, which can take up to 2 years, and in some cases, which we're not going to talk about, longer. And that would be very much the gold standard, where ideally all possible measures are taken to ensure that there's bias and error are avoided and that all the evidence is identified and included appropriately. And obviously 2 years is a long time to wait for information that you need to make a decision, and there's been an increasing move towards people doing rapid reviews, which adopt some trade-offs between rigor and speed, both in the terms of the question they address. For example, looking at a narrower question set than you might otherwise want, and in terms of the processes that you use. So you might not use duplicate processes for all aspects of the review, for example. And they're, a month to a year is, the sort of time span that we're looking at there. And Dora is going to talk about an example of a rapid review that we undertook here in the ARC after I finished. At an even more rapid level, we have rapid evidence synthesis, which, as we do it here, is a process for doing synthesis of existing evidence in about 2 weeks, not using 2 weeks of researcher time, which is an even greater level of rapidity with a transparent framework, which sets out very clearly all the trade-offs that we are making to achieve that rapidity. So, as you'll see, we use many of the elements of a systematic review toolkit, but we take approaches that allow us to deliver very quickly. So, what is a rapid evidence synthesis? It's an evidence summary, which is driven by a very specific need from decision makers, and in the ARC that would be around the adoption of innovation across Greater Manchester. So we will get a request for us to provide a summary of the evidence which can be integrated into the decision-making process. And we have developed a framework to transparently set out what we're doing in that way. We've just published a paper which sets out that framework, and that together with the framework and an example are available for anybody who wants to read them now. And our aim, above all, is to provide a good enough answer. This is not a substitute for a systematic review, and it's not a substitute for a rapid review. It is an injection of evidence into a decision-making process to provide a good enough answer to allow people to make informed decisions around the adoption of innovation. So our systematic review-based toolkit includes things that many of you will recognise: PICO, so defining our parameters in terms of population, intervention, any control, outcomes we're interested in, and potentially study design, because we will always look preferentially for existing evidence synthesis. Uses search approaches and screening approaches, identification of key data from relevant studies. We are guided by the risk of bias tools and grade-based approaches, which are a fundamental part of review toolkits, but we are using very rapid approaches where we are guided by these rather than implementing them fully and checking them and all that things you would do normally as part of a systematic review. And we build flexibility into our framework to allow us to address a wide range of decision problems and a very wide range of potential innovations that people would like to see what the evidence is for. So the first stage is to describe the innovation, and that is really key. You need to know what it is that you are looking at and its key features, because quite often, because it's an innovation, there will be very limited evidence on that innovation itself. So what you are going to do then is formulate multiple key questions, which will allow you to look at wider evidence, which will have applicability. And you need to know what the key features are in order to be able to do that. So key questions might, for example, be if you have an innovation that is a particular app for helping people manage their asthma symptoms, your first key question will be the evidence for the impact of that on symptoms and emergency healthcare use. The next key question would be to look at other health and digital interventions for that same purpose. And finally, if you are still not finding good evidence, you may go wider and look at all interventions for symptom management in people with asthma and their impact on those outcomes. So the search is fairly self-explanatory. Then we use the words adjust the focus. For that, you will look at what you found and decide whether you can just answer the question on the innovation you're looking at. Is there enough evidence there? Or if there is not very much and it's not good enough, you will go to the next question and look at interventions a bit like this. And if you're still not finding good evidence, you'll go wider still to all interventions. The aim is to give a useful answer. And we have these flexible question sets, which will also include questions specific to interventions that are perhaps a test, where we will look at both the test accuracy and the impact of being tested. So then we assess the evidence for certainty and relevance, and we are guided in that, as I was saying in the previous slide, by the principles of critical appraisal, risk of bias, and critically grade, which looks at key features of evidence, including, crucially, how directly relevant it is to the decision problem that you have, as well as risk of bias and other issues such as consistency and completeness. And we summarize the evidence, and we're providing a bullet-pointed summary, essentially. We write up evidence, but then we provide a bullet pointed summary for people who lack time and are perhaps not used to seeing evidence presented in this way. And that aim is to provide a good enough answer for a decision maker to inform their process alongside evidence from, say, a business case and public patient consultations. This that I'm going to present now is not a typical rapid evidence synthesis. It's an adaptation of that process for what was a bigger evidence set. So what we did here was we took a slightly wider approach. We took longer overdoing it. And I think this was 6 weeks from being asked for it to being delivered, with a lot of that time being around firming up the decision problem and consultation before moving on to actually doing it. So virtual wards are an alternative to acute inpatient hospital care. And I've popped the definition from NHS England up here. But this is where it's really important to define your intervention in consultation with the people who are asking for the evidence synthesis. Because in practice, you have this emphasis on technology in the definition, but in practice, most people admitted to virtual wards are older and or have a degree of frailty. And as the British Geriatric Society says, within the NHS model, virtual wards for this population will operate in a similar way to hospital at home, which is an established model where the care is provided by a multidisciplinary team in a face-to-face way. So having established that, we made the decision that as well as looking at virtual wards, interventions that were defined as virtual wards, we would also look at remote monitoring, because that was applicable. It was an element of virtual wards. But we would also look at the much more substantive evidence base that exists on hospital at home because of its applicability to the rollout of virtual wards in practice. So, as I've said, we had multiple key questions, but in this case, they are all about the intervention, albeit with that slightly wider definition. Because we anticipated that we would find enough evidence to not need to look at other types of care at home, for example. So we posed the question, what is the evidence from existing evidence syntheses for clinical effectiveness, cost effectiveness, different models and the ways in which they're used in practice, barriers and facilitators to their use, and the experience of people cared for in virtual wards, their informal carers, and of the people providing the care. So, as I said, we anticipated finding quite a lot of evidence, and we did. There were over 30 evidence syntheses which had varying degrees of relevance. Most of these related to the clinical effectiveness question, but there was evidence synthesis for most of the other questions, including evidence that the cost effectiveness evidence base was much less developed and helpful than you might expect for something which is being rolled out at a national level in a wide-ranging way. And there isn't the gap that we found was the lack of evidence comparing different approaches to virtual wards, which suggests it might be worth looking at the primary evidence for that, but that was outside the time remit that we had. We did find quite a lot of interesting stuff around barriers and facilitators and the equity implications of some of those, which at the personal level may mean that patients who have particular characteristics are less likely to be admitted to virtual wards and are more likely to end up with an acute hospital admission. And patient, carer and staff experiences very much highlighted the need for guidance, clear structures, support and involvement of everyone who is part of the care experience, including any informal carers. And those experiences related very strongly to the barriers and facilitators that we identified, particularly the staff experiences around the need for clear structures and team characteristic specifications, for example. So because we did this so quickly, we were able to undertake it in March of this year, present it to local and regional groups in May, contribute to the evidence section of a British Geriatric Society report in August, and we have a paper based on this in press. We've had the proofs for it now, which we hope will be out either later this month or very early next year. So because we were able to utilize our rapid evidence synthesis toolkit, even for this slightly wider and atypical case where it was a national imperative that we were looking at, we felt that we were able to produce timely work which was useful to a range of end users. So I just want to reflect very briefly, and I'll be quiet, but I've made the point that it's not a substitute for a systematic review, but it does provide a transparent method of producing a summary of evidence quickly to meet a specific need. And the flexibility that we built into the framework means it can be adapted to work for a wide range of situations. And it has the potential to provide answers even when evidence is limited, and to express the uncertainty of the answer because of the key role of our grade approach within it. And my final thought that is really my main takeaway from this is that defining the decision problem here remains as important as it does for any other type of work, including a systematic review. And I'm really spending increasing amounts of time making sure that I have got that right with stakeholders who are asking for it. I'm very grateful to lots of people, and I couldn't do any of this work without them. And those are some references if anyone wants to follow up later for the bits of work that I've been talking about. And I'm going to be quiet now. Thank you very much.
Thank you, Gill. That was great. Do you want to stop sharing? Excellent. Thank you so much for that. So as you can see, a really clear demonstration of the benefits sometimes of getting there fastest with the mostest in terms of impact. I think the timing of that was spot on. And as you can see, that's already starting to have some great impact in terms of this really, really live area. So if you've got questions or comments, please hold on to them or stick them in the chat. We're going to move directly on to Theodora, who's going to talk about rapid evidence synthesis in the digital domain, and then we'll get into questions and discussions. So Theodora, over to you.
Thank you, and you should be able to see my slides now, hopefully.
Yeah, that looks good. Thank you.
Perfect. So hi, everyone. My name is Theodora, and I'm a research associate in the digital health team. And I will present to you a rapid review that we did and published with the digital health team. And you're probably already aware of our subject matter, which is did not attend or DNAs. These are the appointments that patients miss without canceling them, without rescheduling them, without informing their healthcare provider. And did not attend are talked about extensively, both in the scientific literature and in mass media, and I would say in more political and policy conversations. First, because they are prevalent. The global average of missed appointments is 23%, and because they are costly to healthcare systems. There's an estimate that annually the NHS missed appointments cost the NHS about 750 million pounds. The problem is also kind of timely because of the backlogs of appointments that were created due to COVID-19. There were delays in care. So now a lot of patients, particularly chronically ill, they need to be seen. And so every appointment slot must be filled, and it matters. There are several interventions that have been developed to reduce missed appointments. Some you may have already received, such as text messages to remind you that you have an appointment this week. And some that are quite resource intensive, for example, patient navigators, which is trained staff that calls up patients that have an appointment and make sure that they don't have any barriers coming into the clinic. And if they do, they help troubleshoot these barriers. There is also a type of digital intervention that has been developed in the last 10 years that basically consists of using predictive models. These are algorithms to identify which scheduled appointments are likely to be missed. So which patients are likely to not show up for their appointment. And the idea is that you could use a model like this, you could use an algorithm like this to predict which of the appointments that you have scheduled in your clinic for next week are not going to show up. And then you could target your interventions, for example, your patient navigator phone calls, to this small number of very high risk appointments. And the idea is that co-interventions to these predictive models could vary. For example, you could choose to double book these appointments that are very likely to not show up. You could use additional text message reminders. These predictive models, they are increasing in terms of availability with time. There are at least 50 published papers describing the development and validation of such predictive models. And they also are increasing in their use in the real world. And that is because they come built in to some electronic health records. For example, Epic Systems, which has a very, very widely used electronic health record globally, it does have a predictive model of missed appointments built in. We, as the digital health theme of the ARC-GM, were invited by the Manchester Foundation Trust to evaluate such a predictive model that they will soon have access to. And we're invited to develop the evaluation of the implementation of this model back in January, February of this year. And so the first thing we needed to do was summarize the existing knowledge on interventions that have been developed as co-interventions to these predictive models and their effectiveness. And this was mainly in order to inform our implementation research, for example, to identify gaps that we could come and fill in with our implementation research. And so for this purpose, we did a rapid review. And the main question we aimed to answer was, what is the effect of predictive model-based interventions on outpatient did not attends and on some secondary outcomes, so costs, staff acceptability, and the equitable effect of these interventions on different population groups. So one interesting thing about this review is that initially, as I said, we didn't have an intention to publish it. We just aimed to create a report for our own use, for internal use, to develop our implementation project. But when we saw the findings and when we started discussing with staff in MFT, we realized that healthcare organizations likely have an interest in this research topic, and they do have gaps in their knowledge that our review could fill. So then we decided that it was worth putting in some extra effort to make this paper publishable. And as you can see, it was accepted and it was published online a day and a half ago. So we did succeed in publishing it fairly quickly. So what I will share with you is what I learned from the process of doing the rapid review for, let's say, internal purposes, but then also for publication purposes. And the first thing I'd like to clarify is how long it took to complete the review. And this is for a person, me, leading the project, who was very familiar with systematic reviews and other types of reviews, but I had never done or even read a rapid review before. So Jill basically had to come and take me by the hand and guide me to the process. And initially, it took me about a month and a half over March and April of this year to finish the review and develop a brief report for the digital health team. But most of this time was not really researcher time. Most of the time was spent in back and forths with the team to finalize the protocol, because several themes of the ARC-GM were involved, and to make sure that the protocol addressed everybody's needs. So keep in mind that the actual review work, the actual researcher work, is very, very brief. I would say about a week and a half for me. But the time for communications in your team, it needs to be built at the protocol stage. So we finished this first version, the first report on the review in April, early in April. And then in July, we decided to put in more effort to publish the review. And what this meant was completing some quality controls, basically duplicating the screening, duplicating the data extraction process, the quality appraisal process with the risk of bias tools, and also doing a grade of the evidence. So at that point, it took another 2 months or so to do that. And again, this was mostly time spent by a second researcher doing quality control, so it was not my time. I would not give you too many details about the methods, because I think this was explained very well by Gill before. But I will try to show you what changed between the protocol and initial report and our published paper, as you can see on the 2 sides of the table. So first thing is that we searched 6 databases. We did include 2 trial registries for unpublished and ongoing trials, and we felt it was important because we were going to do some implementation work, so we should know what other work is happening right now, as this is potentially competition. We didn't find any ongoing trials though. And our initial search, it did not include Embase. Because of its overlap with Medline, we thought that it wasn't worth doing when we're trying to be very, very fast. We then decided to add it when we were preparing for publication, and we decided to rerun our Medline search as well. And this was very useful because first it reassured us because we didn't find any papers in Embase that we might have missed. But also we found 2 papers that were published since our first search, which happened in March. So we had more evidence. Then in our eligibility criteria, I only want to draw your attention to the eligible studies in terms of outcomes. So when we started this project, we knew very little about did not attends as a topic. We knew a lot about predictive modeling, we are in the digital health team, but very little about did not attends. And we were unsure about which outcomes we would find in the studies. And I think this is a difference with systematic reviews where you have more time to be familiar with your topic before you draft the protocol. So we left this criterion fairly open when we decided that we would include studies with any outcome that is relevant to appointment attendance. And we were prepared to summarize findings narratively if we found a lot of heterogeneity. Finally, the initial screening was done by 1 reviewer, but in preparing for publication, we added a second reviewer who independently screened 10% with really high 99.5% agreement. And in terms of data extraction, we extracted characteristics of the studies, characteristics of the interventions, and the predictive models. We're guided by the tidier for that. And in terms of outcomes, as I said, we expected heterogeneity. So we decided to extract risk ratios for attendance outcomes to give you an idea of what the relevant outcomes were. This could be the rate of missed appointments, the rate of canceled appointments, the rate of rescheduled appointments, and of attended appointments, which are all very different things. And we also found some sort of outcomes we didn't expect, such as a continuous outcome, the idle time of MRI machines in an MRI clinic, which basically indicates attendance. This meant that we could not synthesize findings in a meta-analysis, was not possible. Where possible, we chose to provide a median and interquartile range of the risk ratio of the attendance outcomes. And initially, we did define that the primary outcome would be risk ratio of attendance, and then we changed it to risk ratio of non-attendance, of did not attend, because of the availability of data we found. We used the risk of bias and the Robin's tools to appraise risk of bias. Initially, all of this was done by 1 researcher, me, and then a second researcher checked all outcome data and independently assessed the risk of bias. And the last thing we added for publication was the grade assessment. So briefly, grading the evidence indicates trust in the total evidence per pairwise comparison and per outcome. And it takes into account the risk of bias, the inconsistency, the indirectness in the total evidence, and publication bias. And this was particularly helpful for us because GRADE gives you a very specific language that you can use when you present and communicate your results. For example, evidence in which you have high certainty, you would say that the intervention is effective. If you have moderate certainty according to GRADE, you would say the intervention is probably effective. And for me, this made a really big difference in the way I could write my results and communicate them in the paper we submitted for publication. In terms of findings, we included 8 studies, 7 were randomized trials. They took place in a variety of medical specialties in outpatient care, from dermatology to endoscopy to MRI diagnostic clinics. And the studies were, they assessed 4 different types of interventions, all of which were delivered, of course, in a targeted manner to patients that were at high risk of not attending according to a predictive model. And they were all compared against usual care, which mostly means reminders. The interventions were text reminders, phone call reminders, patient navigator phone calls, and overbooking of appointments at high risk of no-show. And of the attendance outcomes we studied, I will only tell you the findings about did not attend, the primary outcome. So based on the GRADE assessment, we found that model-based text reminders reduced DNAs with high certainties. Phone call reminders and patient navigator phone calls probably reduce did not attend with moderate certainty. But for overbooking, we did not find any studies reporting data to calculate non-attendance. And even for other outcomes reported, which were relevant to attendance, it was very uncertain what their effect was because of the quality of the involved studies and the inconsistency between them. As part of our objectives, we also wanted to summarize the evidence on the cost and the acceptability to staff of these interventions. We found no formal complete assessment, but we did a narrative summary of some evidence, which showed that most interventions reduce costs and they are acceptable to staff. There was a lot of imprecision here and a very unclear reporting explaining exactly how acceptability was evaluated. So we decided that these are basically still gaps in the literature. And we also summarized some subgroup analysis which show that reminder interventions, they have a similar effect across socio-demographic subgroups related to equity, but patient navigator interventions did not. Again, we decided that there was room for a lot more research here, and we identified some gaps. So to summarize, the main finding was that predictive model-based reminders and patient navigators probably work at reducing did not attend. We also found some evidence gaps in acceptability, in cost effectiveness, and in equity. There's an obvious limitation to the findings. There was no meta-analysis, so studies were not combined in a weighted manner. And of course, all of the studies came from high-income countries with very digitized healthcare systems. And I would consider that this review, as a final statement, it was a successful project. First, it was published in a very good journal and very quickly. Second, it has already been used to inform our implementation study, our research questions, our interview guides, and so on. And third, when we started discussing with MFT staff, we found out that management has questions about which interventions they can use with the predictive model they have, which interventions are effective and equitable. And now, because we did this work, we have information to give to MFT staff so that they can make evidence-based decisions in the implementation of this predictive model. And that was pretty much all I had to say. And over to you, Peter.
Thank you very much. That was brilliant, very clear. So you've heard the 2 presentations detailing kind of the general approach with some really, really useful specific examples. So now we've got a bit of time for questions. So I can see there's been some chat going on about PPI, which is great to see. But any other questions or comments for our presenters today? Professor Cullum.
So, hi everyone. I thought the presentations were great. Thank you so much for the presentations and for all the work you've done. Got a question which I think is probably mainly for Theodora rather than Gill, but it might be for Gill as well, and that's about impact. And so Theodora sounded very close to MFT, and it sounded like they really wanted the information. And on that last slide, you said they, they might use it for to apply it in different areas differently. I'm just wondering, A, if we know how they're using it, and B, for both of you, I guess, is a question about how we're planning to collect data on impact going forward.
Yeah, it's a really good question. So the stuff that was spoken with in MFT, sort of, there's two types of discussions that have happened. One is discussions that I have had through my implementation research. So for example, at the end of interviews, that's mostly with clinical staff and some management staff, which had questions and then asked me to share the draft of the review with them because they had no idea what kind of interventions they could use with the predictive model. And then there are discussions that I know Dawn Dowding, who is leading the digital health theme and is very much involved with MFT, is trying to set up with more sort of high-level management staff that is involved in the implementation of Hive. The thing is that the slightly hectic atmosphere going on in MFT right now with the implementation of Hive is delaying these conversations. And to your point about evaluating the impact of this review as it's used in MFT, I think what we need is more structured conversations with them, and also sort of not urgently, but they should be prioritized within the next, let's say, 4 to 5 months, because after that the model will go live. So this is the time for them to decide which interventions they want to develop and to use this evidence. But yeah, pragmatically, I don't know if they have the time to go into this type of conversation with us.
Thank you. Gill, did you want to come back on that one?
I don't think I've got very much to add, because I think that's a really nice example of, Dora being able to track what is going forward with her review. Sometimes I'm not completely sure what the impact of the res is on the process, because it's one component. It sits alongside other components such as business case, public involvement, and so on and so forth. But sometimes we know that a decision is made to not proceed with an innovation, for example, and that is often driven, well, not often, but I think in 2 cases that has been driven by the rapid evidence synthesis that we've produced, which has suggested that the evidence is maybe not supportive of going forward with this. In cases where adoption is happening, I think we need to do some longer term follow-up. And sorry, I was just looking at Nikki's comment. Yes, I would agree completely with what Nikki's comment in the chat, that gathering feedback about how it's being used is very important.
Brilliant. Beck.
Hi, thank you both. Really enjoyed your presentations. I was interested in your process in terms of, so the people that you go to, who commission these. So just so the last one, so Dora's one obviously was with MFT. So in terms of when the sort of brief that you're given with these, do people tend to have questions or want or expect certain types of evidence? And I'm interested particularly in qualitative work. So I know the one that you just presented, Dora, didn't look like there was sort of qualitative evidence there. But do you tend to deal with it? And if you don't, just sort of people ask for it, and how do they engage with that, if at all?
Do you want
either of you?
You want to go first, Dora, or
and if the answer is you don't deal with
you can go first, and I can add some reflections maybe from our PPI work.
Sometimes people aren't very clear on what they want, and I would say that's not uncommon. So we increasingly talk to people about what particular questions they want to address, and if it becomes clear that they are interested in barriers and facilitators, for example, we will look for evidence that would address that. We look for the best evidence that will answer the questions we're looking at. And in most, in a case of effectiveness, that's going to be preferably a good systematic review of randomized controlled trials. In the case of patient experience, it's going to be an excellent metasynthesis of qualitative studies, for example. So we look for the best evidence for the question we are addressing, and we try quite hard to make sure we're asking the right questions.
Theodora, do you want to add anything?
Yeah, so I think in terms of our discussions with, let's say, clinicians and management, the type of questions they had, it was very clear and also expected. They wanted to know which interventions exist as co-interventions to predictive models and what they look like. They wanted the description of them, a typology, and then they wanted to know about their effectiveness. And then it's interesting because the discussions we've had with the PPIE panel of ArcGM for this project, they've had a couple of discussions in the past few months. They had questions about what the impact is for patients when this predictive model interventions are implemented, to which we did try to synthesize evidence narratively, a type of thematic synthesis. The evidence we try to synthesize on acceptability by patients and staff, on equitable impact across patient groups. And largely the answer that I had to give the PPA panel was that there's not enough evidence on this, or there's only anecdotal evidence. And so this was useful again, because then they did come back with, well, could you look into this if nobody else has looked into this? So again, it's I think the evidence gaps we present are as useful as the type of outcomes that we present to the stakeholders.
Thank you. So I'm not seeing any more hands. I've got a quick question while people are working on theirs. So Gill, one for you. Good enough. You use that phrase in describing this, and I think it makes perfect sense. It needs to be good enough. I was just trying to unpack that a little bit and what you meant by that, because I suppose it's good enough in what way and to whom. So just interested in any reflections, having done a bunch of these, what you think.
Yeah, we came up with a description of that in the paper that Nikki really contributed to, and I'm going to cheat. I'm going to go and look at what we said.
Nikki can't remember that either.
It was the final version, and we said very clearly what we defined as a good enough answer. Good enough is considered to be an up-to-date evidence summary, which is based on the most relevant and methodologically rigorous evidence available, with uncertainties clearly articulated and acknowledged. Okay.
Because I suppose in a sense that, as I think you indicated earlier, if you do one of these, you're going to there's compromises. There's always compromises. If you want speed within the same sort of envelope of resource, there's got to be compromises on quality. And I suppose it was just what your reflections were, where the compromises sit most comfortably. Because I always, I've not been at the sharp end of reviews for many years, but in terms of the scope of the search, to me, often it seems overblown. The amount of searching we do, the amount of quality assessment and the detail of quality assessment, I think a lot of that tends to, well, for me, I've never seen that had a big impact. Do you have a sense of where the compromise, where you're most comfortable making compromises with reviews?
As a Cochrane author, I'm scared stiff by the whole thing.
Good thing. That's
terrifying. I have to learn to live with that, and the fact that I'm being we're being extremely clear about what we are and aren't doing. And I suppose I worry most that we have missed something really important. And I also worry that I've had a bad day and there's no one there to pick up on that, or that, that I will make stupid mistakes and not catch them because of the speed, I guess, is what I worry about at a human level.
No, I get that. I suppose my impression is that few reviews are so frail that one study that you happen to miss would fundamentally change anything. It's rare, and it's a common concern, but it's rare you see it in reality where somebody says, oh, you missed this study and now everything's different.
Yeah.
There's other questions. So I'm going to start with Chun-Hugh and then Paul.
Thanks, Pete. I think it's a question to Dora. And in your presentation, because of the time limitation, you probably cannot present everything. So I just wonder what you find out about the intervention. You mentioned you use the tidy to assess the completeness of the intervention. And I suppose the intervention should be complex to cover both the predicted model and also the approach they used to notify the patient, for example, the text message, the phone call, and the navigator. And you labeled the interventions as the patient navigator, the text message. However, there's no information about the predicted model. So what the findings, or maybe what's your judgment about the predicted models part, used in the intervention?
Yeah, it's a really good question. There are a lot of things that there was not enough time, both in the presentation and in the paper. There was not enough space to present, so they went into an appendix table. And one of these things was a description of the predictive models that were used to select the patients that were then receiving these interventions. One thing that comes up a lot in digital health is the description is often not detailed. So there is a lot of things that I want to extract about the predictive models that were not clearly reported, neither in the included paper nor in the papers they cited, previous papers describing the models. So first, there's some missing information. And second, there is some perhaps flexibility in how these interventions are built and delivered. And this is, I think, the case with all multi-component, non-pharmacological, complex interventions. So for example, among the different interventions where it was reported, there were different thresholds taken from the probability that an appointment won't show up, according to the model, at which the intervention was delivered. So for example, one intervention was delivered when there was over 80% probability the patient won't show, another when there was over 70% probability. And sometimes this was selected very arbitrarily, based on the feasibility and the resources that the local context had to do the interventions, such as the phone calls to patients. And so an important point with these interventions is always that the local context needs to be very well informed about the description of the interventions when they read the results on the effectiveness. And they need to sort of then brainstorm internally to decide how they will adapt them to their needs and their resources.
Yeah, I agree. So it's probably a comment about this. You mentioned MFT might continue the talk with you about the implementation of the evidence. So I just wonder, if we don't know what the predicted model looks like, it's probably, this probably limits the implementation, because I suppose the predicted model should be a combination of different variables. So if we, for example, know nothing about the variables included in your model, then it's really hard to use it in practice.
Yeah, so it's again a really good question, and we are doing some implementation work. We're doing some interviews with MFT staff right now, and we have some information from Epic Systems, which provided this model about what the model includes in terms of predictors. And it is being locally validated right now with the local patient population. And there are several things that come up that are specific to the context, as you say, that have to do both with the trust in the model, because its accuracy has not been demonstrated yet, and because it was developed in a different context in the United States, not in England. And there's also issues about what type of intervention would be preferred out of the interventions that I found exist in the rapid review. because, for example, some interventions might be too resource intensive for a specific clinical unit. Patient navigators might be way too resource intensive for a clinical unit that has a lot of no-shows. Yeah, so this again are conversations that we are having right now while studying the pre-implementation phase of this project.
Thank you. Paul, are you retracting your question, or are you?
The conversation's moved on a little bit, so yeah, I'll leave it.
No, I mean, we've got 5 minutes if you want to come in.
Yeah, I was just going to reflect on the good enough bit, and I think it's not a question of being scared about what's missed. Actually, what the process offers is transparency. These decision-making processes that we're helping inform would be happening regardless. And then actually, you know, by doing it in a systematic way, even though it's rapid and fast and there's, you know, a chance that stuff might be missed, actually all you're doing is providing an audit trail for the role of evidence in those decision-making processes. Just reflecting on these two presentations, one of the things Nikki's sort of said this is perhaps we need to get better at capturing what happens in that decision-making process, or the decision that's finally made. But you know, that I think we should all be comfortable that we're offering something that's actually quite transparent and offers a degree of robustness to a decision-making process that wouldn't otherwise be there.
Thank you. Thank you. Theodora, Gill, do you want to respond to that, or?
No, I was just going to say that I think it's really important that we acknowledge that what it is and what it isn't. You know, and it's definitely a lot better than not inputting evidence into a decision-making process at all. But it's not a substitute for doing a proper review, a systematic review. What Dora did was a very rapid review, had a formal protocol, and so, you know, it was a much. It's a halfway step between the two, if you see what I mean, between a rapid evidence synthesis and a full thing. And this process of actually doing checks after you've delivered an answer is actually not a bad way if you want to check up on what you're doing. It allows you to deliver the answer rapidly, but then also do some quality control for your own benefit and that of a wider audience. And it's sort of a backwards way of approaching it, but I think it can be quite effective in a pragmatic situation.
Okay.
Yeah, and I would add to that of course, in a rapid review process, there is a single person doing the screening or the quality control or data extraction, and there's the risk that you're having a bad day and you're making mistakes. But if you leave the task up to a person that's very experienced, like Gill, for example, then well, as my quality control, I will say that I'm somewhat experienced with systematic reviews in the past. As my quality control showed, there isn't that big a risk for important mistakes.
Thank you.
I would agree with that. You know, as a second reviewer, you don't catch a lot from an experienced first reviewer, generally.
Okay, so I'm going to draw this to a close now. So thanks. Clearly a lot of anxiety amongst the systematic reviewers in the room. So that's something obviously we need to look at in the future. I think just as a reflection, one of the things I think will be interesting, in a sense, you've gone down a kind of rapid artisan review using sort of standard reviewers, as it were. And I guess one thing I'd be interested in the next 20 years, whether essentially technological advances mean that we can do formal systematic reviews over a 2-week period using various technologies to speed the whole process up. So I think that will be an area to see where we land up, whether this remains something or it just gets replaced by technologies as we move forward. But anyway, great presentation. Thank you so much. This has been a massive success for ArcGM. We're very proud of all that Gill and others have accomplished. And I think the hunger for this amongst the commissioners and so on is a real indicator of its success. So lovely to have it advertised today. Thank you so much to everyone for coming along today. If we can express our appreciation for our speakers in the traditional virtual way, we shall hopefully see you all again soon. Thanks so much for coming. Thank you so much to Gill and Theodora for an excellent presentation, and we shall see you all soon.
Thank you all.
Guys. Well done, guys.
Oh,
You can relax now.
Steve.
You are